Good morning, everybody. We are going to continue with this really interesting session that is focused on the 2022 ESC Guidelines on Cardio-Oncology. And in fact, we are honored to be able to receive here at La Paz Hospital such a large amount of experts in cardio-oncology. And I want first to introduce my co-chair, Gabriele Tocchetti from Naples. And I want also to introduce you all the speakers and the discussion panel that we have here in this session. The first speaker was Raúl Córdoba. He's an hematologist at Fundación Jiménez Díaz, and he's the representative of the European Hematology Association in our task force. And of course, Dr. Alexander Lyon, who is my co-chair at the ESC Guidelines. He's based at Royal Brompton in UK. Daniela Cardinale from Milano, Dimitrios Farmakis from Athens, and Peter van der Meer from Groningen. So all of them are part of the task force members of the ESC Guidelines. So I assume that you have a lot of questions for them, and we're going to try to have a good time for discussion at the end of the session. So we are going directly to move to the first talk, and Raúl Córdoba is going to present us the onco-hematology perspective of this first ESC Guidelines on cardio-oncology. And I think that it's really, really important that you bear in mind that these guidelines are a collaborative effort between oncologists, hematologists, radiation oncologists, cardiologists, pharmacists, and in fact, we need all this expertise on board to be able to create this document. So without any ado, I give the floor to Raúl Córdoba. Thank you, Raúl.
Thank you very much for the introduction and also for the invitation to join this international symposium and also to be a part of the task force to develop these guidelines. So today I am here to give you some tips about how to pick up some interesting data, the essentials for onco-hematologists, the point of view of a clinician that is going to treat patients with cancer. So before I start, I want to point out the complexity that we have already seen in the previous presentations. The complexity that we are now facing when we see a patient with cancer needs a more patient-centered approach when it comes to cardiac oncology. We are used to work in the last 1 or 2 decades in a single condition focus. We saw the patient with different conditions. Each condition was assessed and treated by specific specialties, but with a very small communication among them. And at the end, when we are working in a multi-morbidity approach to care, we have to see the person as a whole, and we have to take into account the health conditions and the treatment that can interact, and how these treatments and the disease affects the quality of life of our patients. Also, and as already said previously, we have to check the individual needs of every single patient and the patient's preferences, health priorities, lifestyle, and also the goals that we have to meet between the clinician and also the patient. We have to balance the benefits and risk of giving the patient a specific antineoplastic drug, because at the end, what we want is to improve life, but improve the quality of life, and also to reduce treatment burden and adverse events. And finally, we need to improve the coordination across all services of specialties that we are surrounding a patient. So we have to move from a single condition focus to a multidisciplinary approach to care, and this is the best example in the field of cardio-oncology. And I think this is the best example. We have been working different specialties in the development of this European Society of Cardiology 2022 guidelines on cardio-oncology. I was so humbled and proud to be the representative of the European hematologists to participate in this task force that took more than 2 years in order to get this final document. So as a background, I think we, the hematologists, are aware of cardiovascular toxicity risk over the therapy continuum in our patients with hematological malignancies. So it's a very good point because we are aware of that. And we are used to performing a baseline cardiovascular toxicity risk assessment, at least baseline, but the upcoming new drugs may force us to update our protocols. We do not do the same in every different subgroup of drugs that we are going to use in our patients. It's not the same to prescribe a chemotherapy with a cardiotoxic drug such as an anthracycline and novel agents like tyrosine kinase inhibitors, as I am going to show you a bit later. So we have to update the way of assessing the cardiovascular toxicity risk in our patients. We know that most of our patients with hematological malignancies, most of them are going to be cured, and most of them are going to be long-term survivors. So at the end, our task is not only to cure the cancer, the hematological malignancies, but we have also to take care about the late adverse events. And it's another field of work that we hematologists and oncology must work in this long-term survivor subgroup of patients. Now we are facing new treatment strategies, as you have been seeing in the previous presentation, and we are facing now a different treatment strategy, such as the continuous versus fixed duration treatment. And in the continuous therapy, at least we have to monitor the development of adverse events during the entire life of the patient. So therefore, a cardiovascular risk assessment should not be done only baseline as we are used to do, but also during the therapy continuum and also in the long-term survivors. My talk is split in 2 different parts. I'm going to start with the baseline risk assessment that we have to do before starting any line of therapy in a patient with cancer. And as you can see in this figure, and as you can imagine, not all patients are having the same risk level of cancer therapy-related cardiovascular toxicity, and we can see dynamics of cardiovascular toxicity over the therapy continuum. So first, we have to check the baseline risk factors of our patients, and then which treatment are we going to administer to the patients, because we can increase even higher this cancer-related therapy cardiovascular toxicity. And of course, when we finished, the patient is going to be a long-term, and more comorbidities can appear just because of the age. So again, the risk can be increased during the whole life of our patients. As already said, hematologists are very used to do the baseline cardiovascular risk assessment. We do not have a checklist, but we commonly do this. Check for medical cardiovascular risk factors, lifestyle risk factors, previous cardiovascular disease, and previous cardiotoxic therapies. And we are used to order some procedures like the ECG, transthoracic echocardiogram. And one thing that we have to improve is the use of cardiac biomarkers. In my opinion, at least in Spain, cardiac biomarkers should be measured in all patients that are at higher risk, but it's not commonly used. And in the guidelines are highlighted that these results have to be interpreted according to the patient clinical status, type of cancer treatment, and of course the kidney function. So one thing to be improved in our daily clinical practice is to incorporate these cardio biomarkers in this checklist in the baseline toxicity risk assessment. When we want to start a new line of therapy, not only in first line, but also in the relapse or refractory setting, we should do different kind of procedures, not only the physical and metabolic assessment, but also the ECG and the collecting data about cardiovascular disease, previous cardiovascular disease. And it's not only a question of collecting this data in our chart, in our medical record, but it would be more useful if we can stratify the risk of our patients before starting the therapy. And this is the second thing that we do not do standardized in our daily clinical practice. And this guideline recommends the use of the Heart Failure Association and ICOS, the International Cardio-Oncology Society, risk assessment tools in order to identify which is the baseline risk in our patients prior to receive any kind of cardiotoxic drugs. Here is an example of the table that is in the guideline, and you can see that, for example, if we pay attention to the previous cardiovascular disease, if we are going to give a patient anthracycline, you can see that if the patient had, for example, a thrombosis, it has no score in that. At the end, we have to add all the scores and calculate the risk in low, moderate, high risk, and very high risk. And I want to show you that there are an app developed also by the European Society of Cardiology. You can download it for free, and you can check for the risk level of your patient just clicking in this app that in less than 1 minute you can identify which is the risk of a patient. Here is the example of a patient that is going to receive anthracycline. You can click the patient characteristics and you are going to get the risk of developing a cardiovascular toxicity. Because at the end, we do not have to treat the patients, all the patients in the same way. We have to stratify patients into 3 different risk groups: low, moderate, and high and very high risk, because their recommendations are going to be different according to this risk stratification. So in patients, after the assessment with this HFA ICOS assessment tool, if a patient is classified as a low-risk patient, we can proceed with the oncologic antineoplastic drug, and we are going to refer to the cardio-oncology clinic only if the patient develops cardiovascular toxicity. But if not, we can start immediately the antineoplastic regimen. Those patients in moderate risk, it is recommended a closer follow-up from our point of view, from the perspective of the hematologist and the oncologist, and then again refer to the cardiology only if the patient develops cardiovascular toxicity. But in patients with high and very high risk, it is recommended to refer the patient prior the start of the therapy to the cardio-oncology clinic, and of course discuss with the patient the risk and benefit balance of cardiotoxic anti-cancer treatment, not only with the cardio-oncologist, but also with the patient. So this risk stratification is going to help us in order to individualize the treatment and the follow-up that we are going to offer to our patients. And here are some recommendations. I'm not going to enter into detail because of a question of time. I'm going to highlight only the class 1 recommendation. So cardiovascular toxicity risk stratification before start any antineoplastic agent with potential cardiotoxic activities recommended in all cancer patients. Is very relevant and very important to communicate the results with the patient, because we have to balance the efficacy of the antineoplastic treatment with the consequences of them, that is the cardiovascular toxicity, not only in the short term, but also in the long term. It is recommended to proceed to the antineoplastic regimen without a delay in patients with low and moderate risk factors, but in those patients with high and very high risk, it is recommended to submit the patient, to refer the patient to the cardio-oncology clinic before starting, in order to make the agreement what's the best treatment strategy to give to this specific patient. And in the second part of my talk, I will review with you some details about the surveillance that we should do during cancer therapy. There are a lot of figures in the guidelines that are going to help us a lot. And to sum up the monitoring in patients receiving anthracyclines, we do a transthoracic echocardiogram baseline, but we forget to ask them in the follow-up. The guideline says that even in low-risk patients, we should ask for a transthoracic echocardiogram at 12 months after the end of treatment, and we often miss this assessment. And if you see in the bottom of the figure, in high and very high risk, even every other cycle is recommended to do the ultrasound, and it's not only done in the clinical practice, at least in Spanish institution. So to me, we have to work in the implementation of the transthoracic echocardiogram according to the risk factors and not do only in baseline. And another thing that we have to implement is the cardiac serum biomarkers, at least where they are available, before every cycle and end of treatment at 3 and 12 months post-treatment in the high and very high risk patients. So if we do not stratify patients, we do not know who are going to benefit from this very exhaustive monitoring and follow-up. So my recommendation after the assessment with a validated and standardized tool is to highlight the extensive assessment that has to be done in high and very high risk patients. I'm not going to get into details in the level of recommendation because it has been already covered. Moving to another scenario of BCR-ABL tyrosine kinase inhibitors that we hematologists use in the treatment of chronic myeloid leukemia and some subtypes of acute leukemia. It's of relevance that not all TKIs are the same. They have different safety profile and different cardiovascular safety profile. And we have to check what are the possible adverse events that we can find in our patients in the follow-up, because you have to remember that when we prescribe this drug, it's going to be prescribed continuously until disease progression or grade 3 or 4 adverse events. So it's for the entire life of the patient, despite we are now trying to discontinue these TKIs in a selective group of patients, but the first aim is to prescribe it indefinitely. And what about Bruton tyrosine kinase? That is an oral drug which is used in some subtypes of non-Hodgkin lymphoma and chronic lymphocytic leukemia. The guidelines recommend to monitor the blood pressure in every single visit, and also I also recommend the patient to take the blood pressure at home. Regarding echocardiography, we were not used to prescribe, to order an echocardiography before the start of a BTK inhibitor, but now the guidelines says that it's recommended in high-risk patients before starting the BTK inhibitors. And always when a patient develops an atrial fibrillation, which is a common cardiovascular adverse event that we commonly see in patients treated with this group of drugs. And as we know that we can induce an atrial fibrillation in between 8 and 15% of our patients, we recommend the patients to do a screening for palpitation or atrial fibrillation by pulse taking, and we perform routinely ECGs when the patient is in the clinic. In the field of multiple myeloma, we have a lot of recommendations, and again, the use of transthoracic echocardiogram and even the cardiac magnetic resonance in patients with a suspicion of cardiac amyloidosis is going to increase the procedures that we have to do in patients, but again, select which patients are going to benefit from this exhaustive monitoring, and of course they are those at high and very high risk. These are the recommendations regarding the blood pressure monitoring, cardiac serum biomarkers, and transthoracic echocardiogram. And just to highlight that not all drugs are the same, and we have to be more aware of this cardiovascular toxicity in patients receiving carfilzomib instead of other proteasome inhibitors. So we are going to be the one to prescribe the antineoplastic drugs, but you cardiologists must know that not all drugs are the same. Regarding the thrombosis prophylaxis, it is recommended to use therapeutic doses of low molecular weight heparin in patients with multiple myeloma with a previous thrombotic event with a level of recommendation of class 1, and at therapeutic doses. And prophylactic doses are recommended in patients with thrombosis-related risk factors, at least during the first 6 months of therapy. And with a lower level of evidence, aspirin should be considered as an alternative for the heparin, at least in patients with no risk factors or only one. So patients at high risk, we have to prescribe heparin for the first 6 months because the risk of deep vein thrombosis or pulmonary embolism is really high. Now, to conclude, some words related to hematopoietic stem cell transplantation. Again, we are not used to order the 3-month, 12-month, and yearly after the transplantation. So we have to make an effort to not to forget order the cardiac biomarkers and the transthoracic echocardiogram at least in high risk patients. These are the table recommendations. And to conclude, these are my take-home messages. We need to implement the measurement of cardiac biomarkers in patients at risk of cardiovascular therapy-related toxicity where available, and remember to interpret them according to the patient clinical status, the cancer treatment, and kidney function. It is recommended to perform risk stratification using multiple risk factors to determine the patient-specific risks. Not all patients are at the same risk, and if we want to do a personalized medicine, this is another way to do that. The HFA and ICOS tool should be used using a recognized risk stratification method. So we hematologists must learn how to use it and start using it routinely in our daily clinical practice. And there are specific recommendations for baseline risk assessment and monitoring during antineoplastic therapy for multiple conditions, as already shown: lymphoma, leukemia, myeloma, proliferative neoplasms, hematopoietic stem cell transplantation, and those recommendations are available on these guidelines. So to conclude all my talk, we can wrap up with this sentence: we just need to read the guidelines and we just need to follow them. Thank you very much.
Thank you very much, Raúl. It's great for me to share this session with Miss Guidelines, and the pleasure to introduce Mr. Guidelines. Alex Lyon, please, for your talk.
Thank you, Gabriele, and thank you very much for the invitation to come to Madrid. First of all, isn't it lovely to meet in person after 2.5 years of doing everything on Zoom? And this guideline was created through Zoom. We only met for the first time in Barcelona as a team, and Teresa and I, thank God for WhatsApp as well. It's a very easy way to communicate. So thank you for the invitation to come. Now, I think the most important message is this was a team effort, and Teresa and I got together and we selected the best people in the world to do this, from all over the world. It's not just Europe, lots of people from outside Europe. So this is the Real Madrid of cardio-oncology, okay? So we want to thank everyone, and that includes a patient, Richard Stevens. So we had the patient voice all the way through the development. So heard about this guideline. It's the first ever guideline on cardio-oncology from the ESC and in fact for the world. And it includes definitions, diagnosis, the treatment and prevention of cancer therapy-related cardiovascular toxicities. And there's a whole range of different diseases of the cardiovascular system that we cover in this guideline, the toxicities and how to treat, monitor and prevent them. And you've seen this as a fixed figure, but the whole concept of this process is risk is dynamic. It changes through the journey of the cancer patient. There are factors that alter or influence the baseline risk. Many patients are low risk, and then when they enter the treatment phase, their risk increases, and then if they're well, they remain low risk. Other patients are high risk. Their risk during treatment is higher and at follow-up. And if we monitor and they develop a problem, then their risk increases further, and that has an impact on their long-term risk. So our strategy in the implementation of this guideline is to manage and reduce this risk, both at the beginning with primary prevention, with surveillance to detect problems early and then nip them in the bud, as we say in the UK, with early treatments, and then this end of treatment assessment in the first year as a novel concept to see who's okay and who needs long-term follow-up, and then identify the high-risk patients for long-term follow-up so we can treat them before they develop serious complications. And so then you can have this concept of the likelihood or probability of the risk here on the sort of vertical y-axis and the severity of the problem that we're talking about on the x-axis, and then grade the risk and the severity accordingly. So this guideline has 272 new recommendations. I don't recommend you read it all in one go. You've got to take it in slots unless you suffer from insomnia. But the concept here is that we have sections from the beginning, at baseline, during treatment, and this first year after treatment and long-term follow-up. You've heard from Raúl about the baseline cardiovascular toxicity. Of course, all the way through the patient journey, it's promoting a healthy lifestyle and then detection and management of risk factors and disease. I just briefly want to highlight this new definition of the cancer therapy-related cardiac dysfunction. So this is the left ventricular impairment and heart failure definition, and it was published by International Cardio-Oncology Society earlier this year. And in essence, you have some patients who present with heart failure, and then the severity, mild, moderate, severe, or very severe if they're symptomatic. But a lot of people are being monitored, and they're monitoring their ejection fraction, global longitudinal strain, and biomarkers. And if these become abnormal but the patient's asymptomatic, it's mild, moderate, or severe. And here's a little bit of detail about this. And I just wanted to highlight the numbers from the asymptomatic perspective. And this is important when we go on to management. So severe are the people with a new fall of their ejection fraction to below 40%. Moderate is where the ejection fraction's fallen to between 40 and 49%. If it's a fall of greater than 10%, then that's sufficient to be moderate, whereas if it was from a baseline such that it's less than 10%, you also need the fall in global longitudinal strain and or a rise in biomarkers. And for the mild asymptomatic CTRCD, the ejection fraction remains stable above 50%, but it's the monitoring that's detected a new fall in global longitudinal strain and or a new rise in cardiac biomarkers that's mild asymptomatic CTRCD. So this is the new definition. There's also some definitions for myocarditis from checkpoint inhibitors. Of course, if you get a biopsy, then that's a definitive diagnosis, but clinically, most patients don't have a biopsy. And so the definition here is a new troponin elevation plus a major criterion, which is a cardiac MRI with a clearly diagnosis of acute myocarditis, or two of the minor criteria. But importantly, you've got to have excluded acute coronary syndrome and infective myocarditis. And in the world of COVID, that becomes more complex because there's a lot of COVID-induced myocarditis out there, and those patients can then be on checkpoint inhibitors. So imaging is key, and we have guidance about imaging. First of all, if you look on the right, you'll see that echocardiography is recommended as the first-line modality to monitor cardiac function, and 3D echo is recommended if it's available, and global longitudinal strain is recommended. And those are all class 1 indications for patients. And if echocardiography is not diagnostic, poor pictures, which of course in oncology patients is quite common if they've had surgery to the left breast or the left chest or radiotherapy, then cardiac MRI is the second line as a 2A. And you'll see on the left here, we mustn't forget the right ventricle as well as the left ventricle, which is where the main focus has always been, and how we measure function, including global longitudinal strain on echo, or function and strain using cardiac MRI. So let's move on to the management of cancer therapy-related cardiovascular toxicities. And I think it's important, particularly for the cardiologists in the audience, to highlight that this is a guideline where the management of these conditions is different to what the non-cancer patient with these conditions would have. Because otherwise, we've got guidelines for the management of heart failure, hypertension, arrhythmias, but this guideline focuses on where there's something different in a patient who's got cancer. And of course, a lot of that is because we need to balance cancer symptoms with cardiovascular symptoms, the prognosis and context, are they curative or is it metastatic, or are they now in a chronically controlled disease state but need continuing treatment? What are the alternative non-cardiotoxic cancer treatment options? Cancer drug and cardiac drug-drug interactions, and in the data supplement there's a full extensive list of the drug-drug interactions, so before you prescribe cardiac drugs, if you've got a concern, you can check they're safe, and of course the patient voice in this. And we cover all these different ranges of cardiac and cardiovascular complications of cancer therapies, and I won't go through them all, but I've got some selected topics for interest. So let's start with how you manage anthracycline chemotherapy-related cardiac dysfunction. So if you look at the top third, what you see is, of course, it depends on what their state is, the definition of their condition. Are they symptomatic or asymptomatic, and what's the severity? Because this then guides your management pathway. In the middle section of the algorithm is the oncology treatment strategy. So at one end, if you've got symptomatic, severe anthracycline-induced heart failure with an EF of below 40%, you're going to discontinue the anthracycline chemotherapy, and it's probably highly unlikely you'll restart, although an MDT process can confirm that. And if it's moderate, symptomatic, or moderate or severe asymptomatic, you interrupt the anthracycline chemotherapy, and you wouldn't restart until an MDT has reviewed the case. If the patient's symptomatic and mild, then an MDT should decide, whereas if they're asymptomatic and on surveillance a mild change has been detected, then you continue the chemotherapy. You don't stop it just because of a drop in GLS or a rise in a biomarker if the ejection fraction is stable and the patient is asymptomatic. And then in the lowest third is what the cardiology and cardiovascular treatment strategy is. And for many patients in this situation with moderate or severe heart failure or CRT-CD, you'll start heart failure therapy. That's a class 1 indication. And if you have the patients with their mild asymptomatic CT-RCD from anthracycline chemotherapy, then patients where it's a fall in global longitudinal strain or a rise in their troponin, an ACE inhibitor or angiotensin receptor blocker, so it could be both or either of these, or a beta blocker should be considered. That's a 2A indication. And of course, the selection may depend on their hemodynamics, their heart rate, their blood pressure, their other risk factors. And if it's solely a natriuretic peptide increase, then that's a 2B indication, may be considered. So once you understand that structure of the algorithm, you can see across the guideline a similar pattern. So here's the one for patients receiving HER2-targeted therapies, such as trastuzumab for HER2-positive breast cancer. And again, it's divided according to whether they're symptomatic or asymptomatic and the severity, the oncology strategy in the middle third, and the cardiovascular strategy in the lower third. Here, I'd just like to highlight one important change from previous practice. So in patients who have asymptomatic CT-RCD of a moderate severity, so that's where their ejection fractions fallen to 40 to 49%, and they're asymptomatic, continuing the trastuzumab or other HER2 therapy should be considered, a 2A recommendation. So rather than stopping, which was previous practice, we actually recommend continuing, but with close cardiovascular monitoring and starting appropriate heart failure therapy. If it's a mild asymptomatic CT-RCD with a fall in global longitudinal strain or a rise in biomarkers, then using ACE inhibitors, ARBs, and or beta blockers should be considered as a 2A whilst closer monitoring. What about the management of immune checkpoint inhibitor-related myocarditis? So first session this morning, we saw the explosion of these drugs, and it's not going away, it's increasing. There's a tsunami of trials coming through and new indications. So we need to understand how to manage this. So once a diagnosis has been made, then every patient should discontinue their checkpoint inhibitor. There are rare exceptions where they may restart, but for the time of the diagnosis, you stop as a class 1 indication, admit the patient, they need continuous ECG monitoring due to the arrhythmia risk, and they should all be started on high-dose intravenous methylprednisolone for the first 3 days, and that's all class 1 indications. Then subsequent treatment depends on whether they recover, whether they're steroid refractory, and how unwell they are and hemodynamically unstable with fulminant myocarditis. And if you are recovering and switch to oral, it's then a weekly dose titration, reducing the prednisolone with troponin monitoring. I'd like to highlight that, and that's a class 2A indication. So we can move to hypertension, very common in patients with cancer, particularly due to a whole range of cancer drugs, maybe the most common being the VEGF tyrosine kinase inhibitors. Now, the way the guideline team approach this is that the cancer patients are different because we're not worried in some patients about their 20-year risk, which is what most blood pressure trials are looking at. So if we take two extremes, if you've got a patient with metastatic cancer, here looking at the left-hand panel, but on the right side of it, you can see if their prognosis is less than a year, then if their blood pressure is below 140, we would do nothing. Between 140 and 159, we may treat it. It may depend on a number of different factors, whereas we definitely treat above 160. Conversely, if you're a cancer survivor, on the left, it's like the normal population. And then in between are different balances. Of course, this is in asymptomatic hypertension. And on the right, we have an algorithm for how to treat a cancer drug-induced arterial hypertension based on the severity with using either ACE inhibitors or angiotensin receptor blockers plus dihydropyridine calcium channel blockers in patients with high blood pressure as class 1. And what you'll see is we essentially do not recommend using diuretics. Now, if a patient's congested, it may be different, but the use of thiazide diuretics routinely in cancer patients with a drug-induced hypertension is not first line compared to the general population. We cover this very difficult topic of choices of anticoagulation in patients with cancer, both for atrial fibrillation and for venous thromboembolism. And you know that AF is much more common in cancer patients for a whole range of reasons, as highlighted here on the left. And in this anticoagulation strategy, we start with the CHADS-2 VAS score, but then we adapt it. And there's the TBIP approach, and this was actually developed by Dimitrios here in the panel. And essentially, we want to look at the cancer-related thrombosis risk, the bleeding risk, which has a number of factors, both because of the cancer itself and also thrombocytopenia from the treatment. Have they had active bleeding? And then interactions between cancer drugs and different anticoagulants and what could be safe or need to be avoided. And again, the patient choice at the end. And then you have an algorithm based on the patient. If they've got high bleeding risk, there's no anticoagulation. If it's not high, then obviously some patients still need warfarin if they've got a mechanical valve or mitral stenosis. And if not, there'll be then the group who could have a direct oral anticoagulant versus low molecular weight heparin based on bleeding risk in particular. QTc prolongation leading to arrhythmias, another common problem in cancer patients, not just because of drugs, but also because often they have electrolyte disbalances. They're on a range of other treatments, such as antiemetics and antibiotics that could prolong the QT interval. And then we know that there are a range of cancer therapies that do, and on the left are those that are known to do the greatest QT prolongation, but many have a mild or moderate effect. And on the right, we've got a structured algorithm here for how to manage this. Starting at the baseline, is the QTc interval acceptable? And then you go down the left, or is it prolonged? And then if you're starting a patient on a cancer drug, which we know can cause QT prolongation, monitoring and then an algorithm to guide you based on what happens next. If it's prolonged, generally interrupt, and then what happens after the interruption? Does the QT interval come back to normal, or does it stay partially or severely prolonged? So that's all during treatment and the different toxicities. Then we've got this concept of, now the patient's finished their cardiotoxic treatment, let's have an end of treatment assessment within the first year. There are a range of factors that might already highlight a high-risk patient where this should be done early at 3 months versus moderate and lower-risk patients where it's done at 12 months. And here are the list of the different risk factors. Of course, if you've developed moderate or severe cancer therapy-related cardiotoxicity during treatment, whether it's LV impairment, myocarditis, arrhythmias, or severe vascular toxicities, then clearly this is a higher-risk patient. Now, we also have the concept of people who've been on treatment, started cardiovascular heart failure therapy because of a dysfunction of their heart. It's got better, they've continued treatment, and now they're finished. Who needs to stay on lifelong treatment, and who could have that heart failure treatment successfully withdrawn and weaned? So this is an algorithm after completing cancer therapy in those people who did develop CTRCD to say, what do you do next? If it was severe or very severe, it's lifelong heart failure therapy. If it's mild or moderate, have they recovered completely? If not, then it's lifelong heart failure therapy. Whereas if they've made a full recovery, then we recommend an MDT, looking through all these different factors to work out who's at risk of future dysfunction if we withdrew therapy. And if they're low risk, then it's a class 2A to start weaning the therapy, the ACE inhibitors and beta blockers, but of course you then monitor the heart function afterwards. And there's then moving into the section on long-term survivors. Now, we can think of this group of adult patients in two parts. There's the adults who are survivors of childhood and adolescent cancers, and they're established risk scores from international collaborations of pediatric oncologists and cardiologists. And then there's the adult survivor of an adult cancer, and what their risk is, which can depend on the treatments they've received, plus their baseline heart risk, or did they develop toxicities during treatment. And then on the left, you can see what the guidance is of how frequently moderate or high-risk patients might need long-term surveillance. And this is dynamic, and at 5 years, people can have a reassessment, and they may have switched from a moderate group into a lower group, or they may conversely have developed problems and become a higher risk. So we then cover all these topics in the survivors. I'm not going to go through them, but they're there in the guideline for your reference. Finally, there's a clinical section on what we call special populations. All our patients are special, but some are complex and more special. So we have patients with cardiac masses, including cardiac tumors. We have the patients with carcinoid syndrome and carcinoid valvular heart disease, patients with multiple myeloma who develop cardiac AL amyloidosis, and a small but growing population of the women who are pregnant then to get diagnosed with a cancer during pregnancy that requires anthracyclines. So the female heart's got the double hit of pregnancy plus anthracycline chemotherapy, and how to manage those patients. Also a special section on the patient who's got an implantable cardiac device, such as a pacemaker or defibrillator, who then needs radiotherapy, and how to manage them. A lot depends on whether the device is within the proposed radiation field, if it's a thoracic malignancy or breast cancer, versus if it's in a radiotherapy to a remote part of the body. And the risk, are the patients pacing dependent or having lots of ICD therapies, yes or no? What's the dose of radiation? And is the device within the radiation field or not? And then we have algorithms that, again, can help you manage the patient safe and their device safely during their radiotherapy. So, 272 new recommendations. 57% are Class 1 and 28% are Class 2A. So you could say there's over 3/4 there that give you a relatively strong guide of what's the right thing to do. Unfortunately, 3/4 have a level of evidence C. So we talk about gaps of evidence. This is a field crying out for more research, and particularly clinical trials, in order to establish the best treatment. And of course, we're following a very fast-moving field in modern oncology. There's lots of educational tools, and Raúl's mentioned the app, which I'd encourage you all to download, because many of these algorithms you can follow for the patient in front of you in clinic using the app, which is interactive and baseline risk. And for our patients, there will be a patient summary of the guideline, which we hope will be translated into Spanish and all languages. So I want to finish by reminding everybody this is at the European Heart Journal online for you to review, to thank again the team, Real Madrid, who delivered this to you. Now, when I looked after 1 week, there had been almost 20,000 visits to this web page in the European Heart Journal, and I had another look last night, which is just under 3 weeks, because it's 3 weeks tomorrow. So we've had 58,000 visits to the web page, and over 19,700 downloads of the guideline. So hopefully this is going to impact care and improve the outcomes for cancer patients, both during their treatment and survival. And I'd like to finish with a comment, which is, in the last week, the UK have been through quite an emotional roller coaster, because a very special lady died, and we all sort of reflected on her life and what she's done. And I think, I said it last night, here in Madrid, you've got the queen of cardio-oncology. So Teresa has delivered such an impact. La Paz Hospital is known on the world stage for cardio-oncology, and she's been a terrific partner and friend as we develop these guidelines together, and we really hope that they'll help you look after your patients. Thank you.
This is great. Thank you, Alex, and thank you, Teresa, and thank you to the organization sponsors, La Paz Hospital, and whoever for having this great meeting. And I share Alex's word. It was great to meet finally in person. It was absolutely. I think Teresa has some question from the audience, from the WhatsApp.
Yeah, we have a lot of people from Argentina connected through the streaming of this meeting. Of course, if you have question, please raise your hands and we can give you a microphone and you have the opportunity to ask your question. So the first question is for Dr. Córdoba, and Silvia Majul from Argentina wants to know, what do you think is the main reason of the underuse of biomarkers, and what are the main strategies that we can implement, you can implement as hematologists or as oncologists to improve the use of biomarkers in daily practice?
I think the main reason is that we didn't know that they were useful. And once we know that we can make decisions regarding the results of the biomarkers, and we see that they are useful to do a more personalized care in our patients suffering from a cardiovascular adverse event, we are going to start using that. I think this is the main reason, and the best strategy to overcome this is to start doing that. In my institution, we started 4 years ago ordering only in patients receiving anthracyclines in the lymphoma clinic, because I was involved in this process, and because we decided how to make decisions about the results. Because at the end, if you order a test and you don't know what to do, the best is not to order that. And when we decide what to do with the results, to stop the anthracycline, to change the anthracycline to a liposomal formulation, or to change the treatment strategy, not to leave the patient without any antineoplastic therapy. If you have clear the decision that you are going to make, it's the best way to start implementing it.
Thank you, Raúl. I think that if we speak about biomarkers and cardio-oncology, of course, we need to ask Daniela her advice on how to implement biomarkers in daily practice.
So, first, to answer the question for the previous question, I think that the very important thing is the hematologist have to collaborate with cardiologists. So this is an easy way to work and to decide when to assess the biomarker. So together we can stratify the cardiovascular risk for each patient and decide the timing, the frequency of the assessment of the biomarker. Biomarkers are very cheap, so I think it is very easy to include biomarkers in the evaluation of this patient. This patient undergo regularly hematochemic control, so to use a biomarker in this routine is a very easy way, and we give us very, very precious information about the prediction of cardiovascular events.
Thank you. I'd just like to add one comment on the biomarkers. So if you go to the guideline for each of the different cancer therapies where we think they're relevant, you've got guidance on what to measure in terms of troponin, natriuretic peptide, or both, and how frequently, depending on the risk. What we didn't do, and this was an active decision, was give a cut-off threshold to say, if it goes above X, do this. And this is because every hospital has a different assay. And if we look at troponin, you know, which assay? Are you using a high sensitivity or conventional assay? Daniela's work was mainly using conventional troponin I, and therefore you think about thresholds of above 40 or even above 80 as where the clinical events get predicted. But we now live in a world of high sensitivity troponin. So I think it's a responsibility of your cardiology team, together with your oncologist, to decide at what thresholds on your hospital assay you would start to make a change and where that mild asymptomatic CTR-CD threshold is.
Yes, sorry, we had an experience in our randomized multi-center trials on the prevention with enalapril and anthracyclines treated patients. And we include 21 centers. Each center used the assay troponin methods assay local. It was local. So we have results from 21 different centers. But it worked. The meaning of troponin rise is confirmed in all the centers. So every center used a different threshold, but it worked.
Yeah, if I can make a comment on the use of biomarkers, I think that the most important thing is to find a way to incorporate their use, not only for biomarkers, but for anything new that we add into clinical practice, to incorporate it into the normal workflow. This is how it's going to work. For example, if we need for a patient to have the troponin monitored every cycle during chemotherapy, we can incorporate troponin measurement in the hematological, the full blood count that we do every week to check the hematological toxicity, for example. So we should find a way to add this to the normal workflow. Otherwise, it won't be easy to incorporate. So, for example, add the troponin measurement during the last full blood count that we do before the next cycle to check for toxicity. And another thing, a very important thing, is that one of the reasons that you won't see any thresholds in the guidelines is that particularly for the very sensitive biomarkers like high sensitivity troponin, each patient seems to have his or her own normal values. So what is important to us is to monitor the change in the biomarker. So that's why we need a baseline measurement. And if the baseline measurement then, if it is measured in the baseline, we should measure it at the baseline if we're going to use it throughout the follow-up of the patient. So we have the baseline value and we can control its value that the patient has during the follow-up against his or her baseline value. Otherwise, there is no reason to measure it at baseline if we're not going to use it throughout the follow-up. Thank you.
Thank you, Dimitrios. We have two other very interesting questions from Andres Daniele, also from Argentina. And I think that you all can comment on that. The first one refers to the weaning of heart failure medication in patients who recover cardiac function at the end of cancer therapy. So how can we safely organize this weaning off of heart failure medication? Maybe Peter can start commenting.
Well, that's a very important and also a very difficult question. And I think what's very important is that you really stratify the patient to high risk and low risk. And so I think it would be very different if a patient would, during the treatment, for example, with the anthracyclines, would develop an ejection fraction of, say, let's 25%. You give them all the 4 pillars for heart failure treatment, ACE inhibitors, beta blockers, MRA, SGLT2 inhibitors, and the ejection fraction improves again. So you stop the therapy, the ejection fraction improves and is normal again. So in these patients, I would be very reluctant to stop it. And I think that's also what we very clearly recommend in the guidelines. It would be a different story, perhaps, if the patients would develop an ejection fraction asymptomatic, let's say 48%, quickly normal again, have been treated for a year with the heart failure drugs, and then, you know, these may be the patients that you could consider to stop these drugs. But of course, always with checking them how they, because it could be also very well be the patients who do develop cardiotoxicity may have another risk factor. I think Borja showed it very nicely in these pigs. Like the pigs don't develop cardiotoxicity, you need a second hit. Like, well, in this case, it was aortic bending. So perhaps you need also, that's also the case in patients. You have a genetic susceptibility. These are the patients who develop it, and the anthracyclines are perhaps the second hit after a risk, a baseline risk. And so you should be very careful, because the patients who do develop cardiotoxicity are really different from the patient who do not. And so I would very closely monitor them if you taper the heart failure drugs.
So just to add to that, I think you'd want to make sure that their heart function had returned to normal. So I obviously echo, and if you're not getting good echo images, maybe MRI to be certain. Mm-hmm. You want to make sure their biomarkers, if they were high, have returned to normal, and that, of course, the patient's asymptomatic. And one of the things that is in sort of clinical practice, which we put in, but again, without giving granular detail, is how much heart failure therapy was required to recover the function. Because you've got lots of women with HER2-positive breast cancer, trastuzumab, bit of a reduction in their LVEF, or maybe it could be just mild increase in their BNP, drop in their GLS. They get put on let's say they get put on 2.5 milligrams of ramipril, and everything recovers. Then they continue the ramipril through to the end, and then you're now in the end of treatment. That's a completely different patient to the one that you just described that need 4 drugs and high doses to get things better. So it's the severity of the toxicity syndrome, the CTRCD, and the amount of heart failure therapy needed to recover it are quite good sensors clinically of who it's safe to wean. And then once you have weaned, you follow them up. You don't say au revoir. You need to get them back for further cardiac assessments and imaging, check their symptoms. And of course, if they were in the moderate CTRCD, they're already, the long-term group would say you need to be having some follow-up every 5 years just to keep an eye on them.
Thank you, Alex. And I think that we have time for another question that refers to the role of 24-hour ECG monitoring in patients at risk of atrial fibrillation, for example, patients who are treated with BTK. What is your advice about using this test, in which patient could be useful?
Okay, so we do not have a clear set of risk factors in order to stratify the risk, particularly for atrial fibrillation in patients with cancer. So there is no, let's say, score that the patient that defines which patient is at higher risk, so we can target him or her with the Holter monitoring and so on. We know that some drugs are very much associated with atrial fibrillation. We know also that the higher the constellation of comorbidities that the patient has, the higher the risk of getting atrial fibrillation. But this is also common also for the general cardiology patient. Who do we screen a lot for atrial fibrillation? Probably the one who has symptoms indicative of atrial fibrillation, along with a constellation of risk factors, maybe an enlarged LA in the echo, and so on. So there is no clear answer to this. It is just a clinical thinking, as in most of the things that we are discussing right now. For example, as with who needs to be stopped from the cardioprotective therapies, for example. It's a clinical art. It's the art of clinical medicine, actually, to define who needs and who does not need Holter monitoring to diagnose atrial fibrillation. Certainly the one who has symptoms indicated, palpitations and so on.
Yes, so just to say there is no recommendation for screening for AF, even in people, say, on ibrutinib or other BTK inhibitors, just because they're on the drug with Holter monitoring. I fully agree, you've got to educate the patients to be aware of their symptoms, but we know lots of patients are asymptomatic. I don't know what life is like in Madrid, but in London, the number of people who are wearing a gadget that tells them their heart rate is just escalating. So you get loads of people coming going, oh, my heart rate suddenly went up to 160. And I think if they're on a drug such as a BTK inhibitor, you can inform them that. It would be a useful thing to keep an eye on, and don't ignore the high heart rate and think it's artifact. So, but we're not advising or recommending that you should be doing routine Holter monitors on patients with these drugs, because there's no evidence that 24-hour window is going to give you good negative predictive value to reassure you if it's absent.
Okay, so I think we need to close the session. We are right in time. The discussion was extremely nice and presentation as well. I think one final consideration, I think heart failure with recovered ejection fraction is crucial in these patients. So the trials that are going on, I mean, in heart failure with recovered ejection fraction have to take care also of these patients, because these are the ones that, thanks to our guidelines, most likely will really recover ejection fraction. Thank you very much.